afternoon, folks. Happy June, happy Pride. Thank you so much for coming to this today, which is our last of the year CFAR seminar series, speaker series. And we are so delighted to have for our final speaker of the year, Dr. Hyman Scott, who's visiting us from San Francisco. And before I give his introduction, I will just put in a plug that this is the last seminar series speaker for the year, but we will have another academic year of speakers coming up in August. And if there are people, investigators, folks that you are interested in having come to UW, please email me, Adrian Shapiro, or my co-conspirator in this seminar series, Jay Lingapa, with folks who you would love to see come, and we will do our best to get them here. We have open schedules on the slot for next year. So, but for today's speaker, I'm just so thrilled to have colleague and hopefully friend, maybe. See how dinner goes. Food poisoning comes up.
You gotta play it cool,
Dr. Hyman Scott, he is the Clinical Research Medical Director at the Bridge HIV Clinic in the San Francisco Department of Public Health. And it's a really exciting model. We're running a research clinical trials unit within a county public health department. He's also an assistant clinical professor of medicine at UCSF, and his research focuses on implementation of HIV prevention clinical trials, understanding racial ethnic disparities in HIV acquisition, and using technology to expand uptake and use of HIV prevention interventions. He's active in several research networks, including the HPTN, the HIV Vaccine Trials Network, the COVID-19 Prevention Network, the CoVPN, the HIV Prevention Trials Network, the HPTN, and the Adolescent Trials Network, the ATN. Dr. Scott completed his BS in biology at Stanford and his MD at Yale School of Medicine and his MPH from UC Berkeley. He was a chief resident, infectious disease fellow and postdoctoral fellow at UCSF, and is currently an HIV and PrEP provider at Ward 86 at the Positive Health Program at UCSF. And is also the medical director for the San Francisco AIDS Foundation, one of the largest PrEP providers in Northern California. So delighted to have you here, Hyman, and looking forward to hearing what you have to tell us about PrEP and HIV prevention.
Great.
Thanks so much.
Thank you for inviting me. Like get the class before. Always helpful. Thank you for inviting me. I'm excited to talk a little bit about some of my perspectives on HIV and STI prevention for some of the most vulnerable and priority populations in the US. I do have many examples from our San Francisco site that I'd like to highlight and talk about how we've been thinking and approaching this locally in San Francisco, and we'll be excited to hear and have a conversation. This is sort of the outline. I want to talk about HIV and PrEP use in the US, some challenges and opportunities, and talk a lot about doxing as well. I have no disclosure. So just as a reminder, we have this national goal that for when this first came out, 2025 seemed like a long time in the future. Now it is not a long time in the future. And so how are we doing in sort of approaching these goals? We talked a lot about EHE and our national goals, and then suddenly 2023 and 2024, we stopped hearing people talk about it. And I think the reason is because we're not going to meet those goals. There is no way that we're going to get to 75% reduction. We've only reached about a 12% decline since 2018. And we've seen declines in two priority populations, which were sort of a focus among MSM, particularly Black MSM, where we had actually seen an increase in HIV diagnoses, and we've seen a larger decline among white MSM. We have seen no decline among Hispanic MSM, and I think that there's a large call now for us to reprioritize our efforts to reach that group. But we are missing our targets. So we are actually seeing, we're missing our targets for EHE, and in many ways, our disparities are increasing. So we're doing worse in some dynamics. So I think that this is a really important time and opportunity for us to refocus on what it is that we need to do. And PrEP is a huge part of this. The goal for EHE is to have 50% of individuals who have a PrEP indication access to PrEP. There is only one group that is meeting that, This is among people who could benefit, and this is the coverage. And so you can see that this blue line has skyrocketed over this time period from 2019 to 2022, and that's for white individuals in the United States. And we have seen a relatively flat, there is some increase among Hispanic and Black African Americans, but again, this disparity is just expanding. So we're already seeing sort of one of the things that is likely driving this. When we look at sex at birth, we're also missing the targets for individuals assigned female at birth. We don't have the same level of national data on individuals who are assigned male at birth and have another gender identity. But in some of the studies that we have looked at, only 32% of transgender women and 28% of transgender men are accessing PrEP. Again, far from our 50% targets, which are sort of agreed upon to really try to address the epidemic in the US. And why? Because this is like actually some data from Australia that shows that in this pragmatic trial, they reduced incidence by 92% from what they thought would have occurred without PrEP. So this is like what the potential we have to achieve in the real world as an example. So this is really, I think, a bellwether for us about where we should try to get to and using PrEP to try to achieve that. And there's a lot of reasons why. I think one of the biggest things is structural barriers. We have a lot of interventions that focus on individual level and some at community level, but there are real structural things that are in the way. These are some data that were presented at CROI by Patrick Sullivan that looked at what is the change in HIV diagnoses at the state level. Overall, PrEP coverage was, I would say, terrible, 5.8 to 15.7% at the highest. But even with that low level, you can see that when you compared those that had the lowest PrEP uptake, or PrEP use compared to the highest, which is still pretty low, you still saw 8% decline in HIV diagnoses. So again, the potential is there, and that we still have a lot of ways to go. There's a whole host of things that are driving this. These are some of the challenges in the US. I've highlighted the things that are stated by staff and users when they're actually doing PrEP versus when they're not doing PrEP. This has become more and more accessible, but one of the biggest things is like making sure our staff know about PrEP and can provide the right information. We have a lot of staff we train into our research site, and some come from the community and some are allies in the community. And generally PrEP knowledge is pretty low, even in San Francisco where a lot of our staff live. So we do a lot of time training our staff. And I oversee all the staff at our San Francisco AIDS Foundation as well. Again, lots of training on PrEP. We just assume because we provide PrEP that everyone knows about it, and that's just not the case. Thinking about implementation, that's a huge challenge when we talk about. We still have some providers in San Francisco. We had a provider tell a participant of ours, that they weren't going to prescribe PrEP because they believed in monogamy. And so we found them another doctor, but it just is a reflection that even in our communities where we assume that everyone is on the same page, it's that individual interaction may have prevented them from accessing PrEP, and ultimately could have led to them having risks that they didn't need to have. And so we have all these lessons at the community level, at the provider level. A lot of the messaging, I'm sure, Stephanie Cohen, when she presented, reminded us that when we first rolled PrEP out, we had a contract that all users had to sign that essentially was risk mitigation. And so we've shifted a long way from that. But some of the providers and messaging around high risk and the idea of a Truvada whore when you were starting PrEP are some of the things that we've worked hard to try to transition away from. And also expanding access. I think generic Truvada has been really useful in many places to increase access. And when we look at our city I'm from, San Francisco, we see also some disparities. We see overall PrEP uptake is about 50% among white individuals and slightly lower among Latinx and Black. We see very low among cisgender women and younger people, and actually quite terrible. And I think this is true in most places among individuals who are experiencing homelessness or people who inject drugs, where we have pretty abysmal PrEP uptake. But one of the things that we've tried to address in San Francisco is this idea of and we were talking a little bit about this with the trainees, is we're doing all these things at the same time, but going in different directions and sort of shifting our efforts towards collective impact that involves all the players who are in the field working together to try to achieve the health of our communities. And I'm going to talk about some projects that are sort of highly and tightly connected to this work, which has actually helped us to focus on what our goals are and where we want to achieve. We also did not achieve our goals, are getting to zero. We didn't get to zero in San Francisco just as a support, right? But I think it galvanized the community in a way to talk about it and engage in it that we hadn't had before. There are different committees. I'm going to highlight the PrEP committee. These are all the collaborative partners that are part of this. So it really is a consortium. And there are different projects that sort of been integrated. I'm going to focusing on transgender women and MSM. So I want to talk about this STAY study that my colleague Al Liu leads. It's a demonstration project for transgender individuals. And it was really about supporting PrEP outreach and uptake among transgender women in San Francisco. We had some interesting findings that actually led to us like having a whole new clinic just for PrEP for transgender women based on some of the community needs that came out of it. So that was really the focus of this. It was really a peer-led, community-engaged program that focused all over the Bay Area and was focused on trans individuals and centered trans individuals. The naming, the photos, the representation was all, it's like stay and sort of these hashtags of stay sexy, stay magical, stay resilient. So all positive things, nothing about risk, nothing about HIV risk and those kinds of things, except on the back. And one of the challenges that we found was that a lot of the staff turned over at the clinic. So you would train staff and then they would leave, that would be train. Starting at a clinic in our community is really hard. It takes a long time. There's all these steps that have to go through. And if you've changed your name, changed your identity, and particularly if someone has immigrated, doesn't have documentation, like all those are barriers for them to access. And it was 6 to 8 weeks for them to get into a clinic. And so we had these massive delays. There was a lot of difference between who was a sort of conversation of who was a PrEP candidate. And one of the things that we found out particularly for women who are trying to access gender affirming surgeries, they didn't always want to tell their providers their sexual activities that they were doing because they thought it was going to put their surgery at risk. And so those are some of the things that came up frequently in the work with our participants. And so out of this, we actually started a clinic at our Bridge HIV research clinic. So this was just a PrEP clinic, and the participants would come in and they would we have a dedicated waiting room. And because we have sort of 7 clinic rooms, generally people are like not in the waiting room very long. So when you come in, like you're the only one there, even if there's like 7 or 8 other people, because everyone is out of the space. There was a trans peer navigator who was the main point of contact via text, was also in the community. We had a lot of flexible hours, lots of drop-in hours. People had coffee and other snacks that they needed, that they wanted. And we had staff that were NPs that led sort of the PrEP delivery and prevention services that all of our participants needed. And the waiting room was reflective of our communities as well. And so I think that people felt really comfortable and that they just came there for PrEP. We didn't have to talk about anything else if they didn't want to, but we were open to talk about anything that they had as a priority. So what we found was that one, that we had more rapid enrollment in the study than all of the clinics. We had more rapid enrollment in 6 months than other clinics had in 18 months. We reached a population that was reported higher sexual activity than those that went to the clinics. And that overall, that PrEP uptake was quite high, at about 87% across, which is pretty high for most of the PrEP studies. Retention was 60%. Retention in most of our studies actually with PrEP are pretty poor, and that we had about adherence about 54 to 64%, which is something that we've seen in our other studies. And as I said, we reached a sort of population that had higher number of factors that might be associated with HIV acquisition with this clinic model than with the primary care model. And so it required an investment, it required addressing some of the structural and social things that we were encountering with our participants in our community in San Francisco, which is quite a trans-friendly community in many places. But again, I think really identifying the issues that were coming up and trying to be responsive to those issues. So what we also found is that we have this national HIV behavioral surveillance. So we monitor PrEP use and HIV surveillance elements throughout. And the study actually had an impact on PrEP use across our population in San Francisco. We did this NHPS before and after the study. So we had a community level impact from this type of demonstration project as well. And so it's something that we're trying to replicate and trying to extend this clinic model so that we can continue this work and continue to offer PrEP specific services for trans identified women in San Francisco through this model. And so as we think about how we're going to expand access to PrEP, so I talked a little bit about our work with trans women, and then for MSM we have daily PrEP, which I think has worked well in some communities for some people, but has not worked for everyone everywhere, and that there are now more options. And so we have non-daily PrEP options that are available, particularly for MSM and trans women. And in particular, there's a high interest in long-acting injectables among some populations, including some studies here, where in Australia, there was almost a 60% proportion of folks who preferred long-acting. And then in this online study in the US, we had about a 25% or a quarter of folks who are interested in long-acting. And I think the data from CAB-LA and the clinical trials is pretty astounding. They stopped these studies early because of efficacy. I'm not going to go over too much of this, but what I do like to highlight is in the subgroup analyses for MSM and trans women that, we saw the highest efficacy, we saw superiority, but we saw the superiority was really driven by young people, MSM, and then Black individuals in the US. So these are all the populations that we want to highlight and focus on for our equity work. And that, HB1003 showed that among incidence and efficacy among US Black transgender women and MSM, that even among this population in a clinical trial with support and follow-up and recruitment of sort of trial participants, we saw that there was a 2.1% incidence of HIV that occurred among those who were on TDF-FTC. That's still pretty high incidence in the US cohort. And that we saw a reduction down to 0.58% in CAB-LA. So really an opportunity to drive down infections. That was, we had such a large reduction in comparison to what we saw with the non-Black MSM and transgender women. So really thinking about CAB-LA, if we need to prioritize it, like what populations do we prioritize it to? I think some of these data give strong support for prioritizing it for Black identified MSM and trans women in the US to address the epidemic that we have locally. There's a lot of problems with CAB-LA for anyone who's doing it, not with the drug, but with everything that goes around with the drug. So HIV testing is one of them, viral loads, difficulty getting access to the drug, how you have visits. We have at Ward 86, we offer CAB-LA and Cabenuva, and our teams are giving like 4,000 injections a month. So it's just like this large number of not 4,000 injections a month. That was 4,000 injections since they started the program. So it's still a lot of injections, but it's taxing on the clinical settings that are often overreached. And then there's lots of questions about what do you do when people miss injections? What do you do for coverage? I'm getting questions still from people about, what's the protected time after your injection? How much time do you have to wait before you can have sex? So I say none, have at it. And then there's coverage and cost. So cost actually has been quite much easier, as most of you all doing this. It's if you're publicly insured. It's really easy to access CAB-LA in comparison to in comparison to privately insured individuals. And on the flip side of this, from a structural standpoint, the ability to generate income from 340B is much higher for CAB-LA in some scenarios, particularly where there's buy and bill. So private providers actually have figured out how to make revenue off of CAB-LA in certain settings, which I think is going to be problematic as this rolls out, because it's likely going to steer disparities again towards in the opposite direction we want them to go. But this is expensive. There's access programs, and you know, I think that it's something that is our team at the San Francisco AIDS Foundation can usually get Truvada for people within 24 hours. And it usually takes 6 to 8 weeks to get them CAB-LA for prevention. So 6 to 8 weeks that someone who might not be, for whom oral pills might not work, is not going to have protection potentially while we're trying to figure it out. And so we've been trying to figure out what are we going to do with CAB-LA, and so we take it to the community. And so we have this project that is focused, it's called BALAP, which is focused on a long-acting injectable in the Bay Area. So it's actually a conglomeration of the East Bay getting to zero, which is our Oakland, Contra Costa County, San Francisco getting to zero, and then Santa Clara County, which is like the Silicon Valley. So it's a collaboration across multiple counties. We have a very mobile community. People work and play in all the different counties in the San Francisco Bay Area. And this is a collaboration with us and UCSF. And we prioritize the communities sort of that I've been talking about. African-American, Latinx individuals, cis and trans women, and also including people who experience homelessness and people who inject drugs, because we saw how bad the uptake is of oral PrEP among those populations. So, you know, I think one of the things that we sort of achieved from some of this work was really that people are really excited about this idea. And they want the access to CAB-LA PrEP. They want to have tools to support it. And so the stakeholders, which are many providers, have lots of desire to have support for this. You know, clients are really concerned about like, how well does this work? Will this work for me? I think for trans women, particularly in the setting of implants or fillers that might impact the ability to get the injection. There's lots of questions about that are not always answered. They're answerable, but not always answered. And I think a lot of stakeholders, in particular clinic medical directors and managers, are really concerned about how much this is going to tax their staff. And particularly when you have high staff turnover and have to retrain people. You know, at Ward 86, we had to retrain, all the nurses had to be retrained in ventrogluteal injections. You know, and they handle, you know, patients who have sepsis before they go to the hospital, but they had to be retrained in ventrogluteal. So I think we underestimated the skills that might be needed to roll out CAB-LA. And so what we found was that that for priority populations, there was lots of advantages, including the you know, pill taking, that there was a lot of people didn't know about this. This is in some communities, but not all communities. And that we couldn't ignore the social and structural determinants of health that are driving these disparities. So housing and food insecurity that, you know, and particularly because we were looking at this Bay Area wide, if you live in San Jose and take the train up to San Francisco, it's about an hour and a half trip. And if you go all the way out to Concord, it can be, you know, upwards of 2 hours. And that's like with minimal traffic. It's heavy traffic, you're looking at a couple hours. And that stigma, racism, immigration status were all elements that were impacting this as well. And that they had to be a full sort of complement of resources that were available. And that particularly for people who are experiencing homelessness, having a drop-in accessibility, individuals who are really good at phlebotomy. And so, you know, this is something we experience in our clinics where, you know, I have my patients who are very difficult to obtain blood from. They only want one person. Like the person who I'm happy with my MA at those visits. But, you know, I think that just like we have with the ventrogluteal, like these are some key things that are really right. And then there's other things that people are receiving. So one of our outreach efforts, you know, came up like clean drinking water was not accessible to all the people who were experiencing homelessness in Oakland. And so like that became an issue that I don't think any of us had on our list. And then there's really a need for having some better workflows to support the delivery. And so there's some key recommendations that came out of this that we're starting to implement and are going to be evaluating. And we're tracking all of the uptake of CAB-LA in San Francisco and work with our other jurisdictions to track that as well with some sentinel sites. We're really creating information for patients to provide educational material, really focusing on the navigators and the providers. I think, you know, for information about CAB-LA, I think, you know, what in particular, the navigators are really who clients want to talk to. They don't necessarily want to talk to us doctors. They want to talk to the navigators because they're more at the peer level. And so we need to have more access points, have workflows, and then having provider check-ins with patients between their visits and other things to help them get into their appointments. And so I think that, you know, for one of our studies, we do like a 7-day check-in, and oftentimes injection site reactions do occur and people are not sure like how to manage them. So having someone to check in with them about that is something they want. These are some examples of some of the things that have come up. This is like the insurance workflow, right? So this is like a nightmare for figuring out how to get someone access to CAB-LA and, you know, working with some of the VE partners. There's like information that sort of compares the different types of PrEP and like what the benefits and advantages are. And then we actually have these standard workflows. Actually, we started using these during COVID, our COVID response. But like for the clinics, so the clinics have documentation about like what you do in what situations. And they feel sometimes like mundane, but I think it really supports the infrastructure that we need to have in place to be able to sort of offer this more sustainably in clinics, especially given all the retraining that happens. It can't emphasize that enough, is that once you have a trained staff and they leave, you know, you don't want your whole program to fall apart because that's when the patients get lost. And we have this advantage in the US now where we have universal PrEP recommendations. In the past, it was very tiered, and we have these great options that we can use for lots of different folks. And so, you know, I think for daily oral PrEP, and this is our messaging, is that like, that's more universal, like everyone that. And then there's some controversy on 211 with the parentheses around for trans women. I personally think that 211 with TDF-FTC is completely fine for a trans woman who wants to use it. And I recommend that they take it with food because it would increase the levels sufficiently in a similar way that any gender-forming hormones with estrogen might reduce it. And then CAB-LA in the same way hasn't been studied for people who inject drugs, but has a broad indication across individuals. And as we have more options, we're going to be able to provide choice. And I think we have a lot of data from contraception that matters a lot. And that in providing choice, you actually increase the number of people who decide to take up that intervention. And that taking a daily oral pill is not for everyone. Getting a shot is not for everyone. Some people want to match their PrEP use with their sexual activity. And so giving individuals those choices, engaging them in the efforts, and there's a few studies that are sort of starting going on through the HPTN, the ATN, and we have a couple of projects also that are investigator driven that are looking at, you know, if providing choice will actually impact PrEP uptake among adolescents and actually Latino MSM in the Americas, the US and South America. So we'll be looking at that. There are some data now from Southern Africa in the SEARCH trial. I'm not sure if many of you have seen these data that were presented at CROI, but really it was called the PrEP Choice Dynamic HIV Prevention Intervention. And the blue bars essentially show that among the different groups that were evaluated, you have overall among women and men, and those who are younger, 15 and 24, and older, which is 25 or older. You see that the coverage for prevention is above 70% for almost all of those groups. And that was in the intervention group that really provided options for PrEP, support for access, and that in the standard of care, that coverage was really low, like around 7 to 12%. And that there was a lot of, and there were no infections among the dynamic choice intervention. So that there was like zero, like we don't usually see that in our prevention interventions. And when they looked at what was different, half of the individuals in a dynamic choice used CAB-LA, still half used oral PrEP, but that was the biggest difference between those two groups. And that more than a quarter used more than one. And so, a quarter of the people are changing their minds and trying something new. And that, they saw no HIV infections among this group that uses dynamic choice intervention. So I think just like Amazon knows that if they give you options when you're scrolling through those pages, right, that you're eventually going to find one that you like and buy it. And that's, I think, where we need to be going with our PrEP choices as well. So hopefully we'll be able to get some data on the use of these options within our clinical settings. We do this now at the San Francisco AIDS Foundation, where we give individuals access. We give them the option for daily oral PrEP with TDF, FTC, TAF, FTC, or 211. We have a wait list now actually for CAB-LA because of all the difficulties with accessing it. And we saw that about 15 to 20% of people chose on-demand PrEP over daily PrEP. And then about a quarter of them actually went back and forth a bunch of times. I think COVID changed a lot of people's, COVID and Mpox changed people's sexual activity patterns. And then they were able to switch back and forth, which I think fit their lifestyles and needs. So I'm going to switch to STIs briefly. And we're not doing so great with HIV, so I think we're probably doing better with STI. And so chlamydia cases are down. That's a highlight. But everything else is not. And, congenital syphilis is up almost 200%. But yeah, there's just cases of gonorrhea and syphilis are going crazy. We see this, primary and secondary syphilis. We have just increasing rates among all groups, and the largest number of cases we have on MSM for the data that we have nationally, and I'm sure you're seeing this locally, you're seeing it in San Francisco. And we have this great intervention. These are data that were presented at Glory. This is for DoxyPEP. And I think highlights that among those who were on DoxyPEP in the randomized component of the trial, 12% incidence in that group versus 31%. And then in the open label extension, you see that, incidence has come down quite significantly among those who are now having access to DoxyPEP. There's a similar study that was, presented by John Michel Molina, showing similar trends among chlamydia and syphilis. And also for gonorrhea. This is time to first gonorrhea. So, these two trials showing similar results. And then in San Francisco, what we're doing is we were the first jurisdiction to offer recommendations in October of 2022, and we moved really rapidly. So City Clinic, I think they beat us. I think they got their program up in 2 days. They wrote the guidelines, so and we started about 29 days later. But we've been monitoring this in San Francisco because we want to know, one, how well is this going, who is using it, and are we seeing any disparities in the use of DoxyPEP? So the two sexual health clinics are our municipal STI clinic, and then our magnet clinic, and then our HIV care clinic. And so you can see that overall, we're seeing about 25% of those coming into the sexual health clinics are using DoxyPEP. We're not seeing any massive differences in the use. Some of the large bars Native American, those are small numbers, and so that's why the numbers are quite higher. But overall, we're seeing pretty stable and consistent uptake of DoxyPEP. It's lower in the HIV clinic, and we've seen that as well. It's a slightly older population. I think our median age is close to 60 now for people living with HIV. And so there's just less interest in it. We saw that actually at our sexual health clinic as well. And so we looked at this at our, at our STI clinic, and two things. One is that those who started DoxyPEP were more likely to have had an STI. So we offered to everyone in the PrEP clinic, and not everyone took it, but the people who did were those who were more likely to have an STI. And then when they started it, it dropped their STI incidence dramatically, actually by more than 50% in less than 9 months. And that was true for chlamydia and syphilis, but not for gonorrhea. So I think that the finding for no impact on gonorrhea is going to be interesting. We're going to be looking at our resistance data. Whenever we look at the data for gonorrhea and the use of antibiotic changes, we see resistance developing. So it's expected that this is happening because we have so much doxy use. Does it change what we're recommending? Probably not. And then we looked at it a couple different ways. This interrupted time series, which essentially looked at after we implemented this, like what did we see? Sort of similar findings. Big picture was that this happened really fast, actually faster than we thought it was, and it was more dramatic. And so we're going to be looking at these data again and seeing where we can end up with our incidence. We have about, I think at this point we had about 1,500 people on DoxyPEP. Now we have, I think, 2,700 people on DoxyPEP. So pretty much our entire PrEP cohort, I think, is going to be on DoxyPEP pretty soon. We see this at the city level as well. So we saw a similar, about 50% drop in chlamydia and syphilis. We didn't see a similar drop in gonorrhea. If anything, there was a slight increase in gonorrhea. We don't think DoxyPEP is leading to increases in gonorrhea. I do think it's going to be something we need to evaluate. If there is risk compensation and there is no impact, are we potentially increasing the risk of transmission? We don't know, but we'll be looking at that. But we're having these massive changes. And I've been pitching without sign off from the STI clinic about, we had a syphilis elimination project in the past, but we don't have the tools, this tool now that we have in a way. So, I think it'll be really interesting to see how this continues to shift now that we have DoxyPEP and more people are using it, given that almost 200% increase in congenital syphilis and, 100% increase in early syphilis that we'd seen before. For those who, I'm sure everyone's seen, the DoxyPEP guidelines have come out from CDC. I would say there are, I'd be interested to hear what people think about them. They're definitely more conservative than the California Department of Health guidelines, which is interesting to say, if you're having sex, doxy's for you. They're more conservative than our guidelines in San Francisco Health Department. I think they're probably more in line with your guidelines here in Seattle. Yeah. And so there's going to be a lot of guidelines movement, I think. And I think, depending on which city and community people are in it, might change their interest or access or understanding of what it is. And then just a few more minutes on gonorrhea, because I do think we're going to need new tools for gonorrhea. I have some reservations about the role of DoxyPEP in real world settings, given what's likely going to happen with resistance for its ability to control gonorrhea, like it has the potential to control syphilis and chlamydia. And the Bexsero vaccine was evaluated in this study and didn't show efficacy. And they looked at it a bunch of different ways and it didn't change their answer. And so I think that this gives us pause. There is another study that's going on. These OMV vaccines have similarities to other Neisseria, which is, we've seen this vaccine effectiveness in some observational studies. There is a large study called MAGI, which is ongoing. It's a phase 3 study. We anticipate enrollment will be completed in the next few weeks, and we'll have data out hopefully in the next year. And this is really to answer the question in a randomized control trial, large randomized control trial. I think we have about 2,300 individuals enrolled at this point, is whether or not Bexsero has efficacy in preventing gonorrhea acquisition after the second dose. So we'll see what we find from this study. As I mentioned, we're close to completing enrollment. It's actually enrolled over 2,200. It's an endpoint-driven study, so they enrolled more than that. And we really gonna, I think, need new tools for both HIV, for STIs, and I think it's really exciting to have the opportunity to participate in many of these studies as we try to find new tools to meet the needs. And also planning for success. So we are not going to make our EHE targets. They're going to have to be redrawn. The sort of goal line is going to need to be redrawn. And I think we're missing something in making sure that we're not, if we don't address the disparities, we're not going to address the epidemic. And I think that we have to center some of our work and our efforts on that. And that expanding PrEP uptake, it is the best tool that we have for prevention. Or one of the best tools we have for prevention, but it's not going to work if we have all these other structural and social determinants that we're not addressing and not part of our programmatic efforts to roll this out and get this to the people who we think might most benefit. And that DoxyPEP has potential to change the trajectory of all of many of our STIs, syphilis, chlamydia, and that we need to make sure we address the equity issues that might come up with this. I think I worry a bit that it's going to be like PrEP, where we had to have people sign an agreement before they started it, and that the confusion that sort of went along with it in the beginning, because there was a lot of different guidelines, might hamper our ability to roll this out in the way that we might want to roll it out. So we'll see where we end up in the next few years with our DoxyPEP efforts, but I think we got a really great tool for addressing the STI epidemic. So I am happy to take any questions, and we have a tremendous group of colleagues, and these are some of our groups. And then this is actually one of the ads campaigns that our staff came up with that's intended to be very sex positive and PrEP focused. So thank you for your attention, and I'm happy to